Hey folks, welcome to another video. In this video we'll be discussing about gallstones or cholelithiasis. Introduction. Cholelithiasis refers to the presence of abnormal concretions or gallstones in the gallbladder. The presence of stones in the gallbladder is not considered to be a disease unless they cause symptoms. Gallstones are common, particularly in Western populations. In the United States alone, approximately 6% of men and 9% of women have gallstones. Patients with gallstone disease may be asymptomatic or may present with biliary colic or complications of gallstone disease. The most common site of gallstone impaction is the ampulla of bladder. Components of bile. One needs to understand what are the various components in bile that can result to the formation of these cholelithiasis. Bile is composed of bile salts or acids, which constitute about 65%, and phospholipids, which constitute about 22%, which are the two major components of bile. Other minor compositions include proteins, free cholesterol, calcium bilirubinate, water electrolytes, and bicarbonate. Bile salts or acids are the hepatic products of cholesterol metabolism. They are water soluble and they have a detergent action which renders cholesterol soluble in the bile. Phospholipids mainly are composed of lecithin. It is hydrophobic in nature and solubilizes the cholesterol within the bile. There are several types of gallstones. The gallstones are composed of a mixture of cholesterol, calcium salts of bilirubinate or palmitate, proteins, and mucin. Based upon the predominant constituents, gallstones are broadly classified into cholesterol stones, brown pigment stones, and black pigment stones. Pigment stone is the name used for stones containing less than 30% of cholesterol. Most of the gallstones are radiolucent in nature, whereas most of the kidney stones are radiopaque. About 80% of the gallstones are mixed in nature in the United States and Europe, whereas in Asia, 80% of the gallstones are pigment stones. Patients with long-standing cholelithiasis have a chronic cholecystitis. Various combinations of cholesterol, calcium bilirubinate, and calcium carbonate can result in the formation of the so-called mixed stones. The size and number may vary and are usually multifaceted and laminated in terms of the contour. They are radiopaque if they contain calcium carbonate. The pure stones are composed of only one substance. The pure cholesterol stones are usually single, spheroidal, and are coarsely nodular and have a translucent bluish-white color or are pale yellow in color. They are not radiopaque, and the majority are in multiparous women owing to alterations in cholesterol metabolism during pregnancy. There is no correlation of these stones with the cholesterol level in the blood during pregnancy. Calcium bilirubinate stones are multiple, small, and are jet black stones that have facets on their surface. They are hard in consistency and are most often associated with a type of hemolytic anemia, like in the case of hereditary spherocytosis, sickle cell anemia, or an artificial cardiac valve. They're also seen in patients who are on long-term TPN, that is, total parenteral nutrition. In extravascular hemolytic anemia, there's an increase in unconjugated bilirubin and a corresponding increase in the uptake and conjugation of unconjugated bilirubin to conjugated bilirubin within the liver. In the gallbladder, some of the conjugated bilirubin is converted back to unconjugated bilirubin, which combines with calcium to form calcium bilirubinate stones. Brown pigment stones. Brown pigment stones is a sign of infection in the common bile duct, and these stones are not seen in the gallbladder and are commonly seen in the Asian population. They're soft and friable in consistency and are not radiopaque at all. The infection deconjugates calcium bilirubinate, which increases the unconjugated bilirubin in the bile, leading to the formation of brown pigment stones. The combined stones are usually large, single stones that are associated with chronic cholecystitis. The term gallstone disease refers to gallstones that cause symptoms. Uncomplicated gallstone disease is the term which refers to biliary colic in the absence of gallstone-related complications. Complicated gallstone disease is a term which refers to gallstone-related complications, which include acute cholecystitis, acute cholangitis, gallstone pancreatitis, gallstone ileus, and Morizi syndrome. Some major factors that are involved in the formation of most of the gallstones. The predisposing factors towards the formation of gallstones include an enhanced intestinal cholesterol absorption increases the total amount of cholesterol that is secreted into the bile by the liver. Another factor is supersaturation of bile with cholesterol. The amount of cholesterol in bile, if exceeds the solubilizing capacity of the bile acids and phospholipids, supersaturation of the bile with cholesterol occurs and results in the formation of cholesterol stones. The third factor is nucleation. Cholesterol crystals precipitate from supersaturated bile, which enhances the formation of cholesterol stones. Another factor contributing towards formation of gallstones is bile stasis. Hypomotility of the gallbladder from inflammation in the muscle wall accelerates the crystal nucleation. Biliary sludge. Biliary sludge is composed of microscopic precipitates of cholesterol or calcium bilirubinate and represents the earliest stage of gallstone formation. Now let's take a look at the various risk factors for the development of gallstones. Increasing age and female sex are important risk factors for the formation of gallstones. Mutations in the hepatic cholesterol transporter ABCG8 confers most of the genetic risk of developing gallstones. Pregnancy is a risk factor for the development of cholesterol gallstones. Pregnancy is associated with both a qualitative change in bile composition and a delayed gallbladder emptying, both of which promote stone formation. Diabetes mellitus is associated with an increased risk of cholesterol gallstones. Hypertriglyceridemia and autonomic neuropathy leading to biliary stasis due to gallbladder hypomotility can also predispose towards the formation of gallstones. Elevated levels of non-high-density lipoprotein cholesterol may be a risk factor for the formation of gallstones. Obesity is an established risk factor for the development of cholesterol gallstones, presumably due to enhanced cholesterol synthesis and secretion. The risk is particularly high in women, in those with morbid obesity, and in younger age groups, in which a threefold increase in risk has been reported. Obesity is also associated with an increase in risk of symptomatic gallstones. Elevations in serum bilirubin levels are associated with the risk of developing gallstones. There are several drugs that can promote the formation of gallstones. Some of the most important ones are listed here. The use of fibrates has been associated with an increase in lithogenicity of bile and increase in the risk of gallstones. Fibrates reduce bile acid secretion by inhibiting the rate-limiting enzyme in bile acid synthesis, namely cholesterol 7-alpha hydroxylase. This results in cholesterol supersaturated bile and stone precipitation. Ceftriaxone can cause biliary sludge. It has been reported with prolonged use at high doses. Long-term administration of somatostatin analogs in the treatment of acromegaly has been associated with gallstone formation. Estrogen therapy is associated with higher rates of gallstones and gallbladder disease. These associations have been noted both in women on menopausal hormone replacement therapy and in men receiving estrogen therapy. Oral contraceptives have only a transient effect on gallstone formation. Women under the age of 40 years and those taking high-dose estrogens as high as 50 micrograms or more have the greatest added risk of gallstone formation. Clinical manifestations: asymptomatic or incidental gallstones. Most individuals with gallstones are asymptomatic. In such individuals, gallstones are detected incidentally on abdominal imaging. The majority of the patients found to have incidental gallstones will remain asymptomatic, and patients who develop symptoms typically report a biliary colic. It is rare for a previously asymptomatic patient to present with complications of gallstone disease without first having had episodes of biliary colic. Symptomatic gallstones. The classic description of biliary colic is an intense, dull discomfort located in the right upper quadrant or epigastrium, or less often in the substernal area that may radiate to the back, particularly to the right shoulder blade. The pain is often associated with diaphoresis, nausea, and vomiting. Despite the name, the pain of biliary colic is usually constant and is not colicky in nature. A heavy fatty meal is a common trigger factor for a gallbladder contraction, and many patients report postprandial pain. This is due to the release of an enzyme called cholecystectomy, which acts on the musculature of the gallbladder wall, causing contraction in order to release bile that is stored within the gallbladder. Postprandial pain is not universal, and in a significant proportion of patients, the pain is nocturnal. The pain typically lasts for at least 30 minutes, plateauing within an hour. The pain then starts to subside, with an entire attack usually lasting less than 6 hours. Biliary colic is usually caused by the gallbladder contracting in response to the hormonal or neural stimulation, forcing a stone against the gallbladder outlet or the cystic duct opening, leading to increased intragallbladder pressure. This increase in pressure then results in pain. As the gallbladder relaxes, the stone often falls back from the cystic duct and the pain subsides slowly. Biliary colic is visceral pain, and there is no peritoneal signs because the gallbladder is not inflamed. The lab tests. The lab tests, including a complete blood count, aminotransferases, bilirubin, alkaline phosphatase, amylase and lipase, are all often normal. Diagnostic imaging. Transabdominal ultrasound is generally considered to be the most useful test to detect the presence of gallstones, since it is non-invasive, readily available, relatively inexpensive, and does not subject the patient to ionizing radiation. On ultrasound, gallstones appear as echogenic foci that cast an acoustic shadow. Here's an ultrasound image of the gallbladder polyp versus a gallstone. Note that in panel B, the gallstone casts an acoustic shadow. Gallbladder polyps have a similar appearance to gallstones, but they do not cast an acoustic shadow. That's how one needs to differentiate a gallbladder stone from a gallbladder polyp. Here's another ultrasound image in a patient with gallbladder sludge. Now in panel A, you can appreciate a large amorphous collection of sludge within the gallbladder, and note that it does not cast an acoustic shadow. Whereas in panel B, the patient was turned onto one side and the gallbladder sludge formed a layer along the dependent portion of the gallbladder. That is what is appreciated here in panel B. The sludge seen on ultrasound represents microlithiasis, which contains lithogenic bile that contains cholesterol monohydrate crystals, bilirubin granules, and a mucus glycoprotein gel. False negative results may be obtained if the gallbladder is completely filled with stones or if it is contracted around many stones. Here's an ultrasound image as shown in panel A, which was obtained from a patient with a gallbladder that contained numerous gallstones. On ultrasound, the stones appeared as one large concretion or gas. Panel B shows multiple stones which were found in gallbladder after cholecystectomy. In acute cholecystitis due to gallstones, the presence of stones in the gallbladder in the clinical setting of right upper quadrant abdominal pain and fever supports the diagnosis of acute cholecystitis, but it is not diagnostic. Additional sonographic features include gallbladder wall thickening to greater than 4 to 5 millimeters, or edema, which can show a classic double wall sign. In panel A of this ultrasound image of the longitudinal view of the gallbladder, you can appreciate small shadowing stones in the dependent part of the gallbladder. The ultrasound also shows a thickened wall in both the longitudinal projection and a transverse projection. The panel B also shows a small amount of pericholecystic fluid. In panel C, the Doppler study shows an increase in blood flow to the wall, reminiscent of the hyperemia of an inflammatory process. These findings are consistent with acute calculous cholecystitis. A sonographic Murphy's sign is similar to Murphy's sign elicited during abdominal palpation, except that the positive response is observed during palpation with the ultrasound transducer. This is more accurate than hand palpation because it can confirm that it is indeed the gallbladder that is being pressed by the imaging transducer when the patient catches his or her breath. Endoscopic ultrasound. Endoscopic ultrasound may identify small stones missed on transabdominal ultrasound. It includes an upper endoscopy, which serves to exclude other conditions like peptic ulcer disease, so on and so forth. Endoscopic ultrasound is more sensitive than transabdominal ultrasound for the detection of gallstones, particularly in patients who are obese or have other anatomic considerations that limit gallbladder visualization with transabdominal ultrasound. Mercedes-Benz sign or seagull sign. The center of gallstone may contain radiolucent gas in a triradiate or biradiate fissure, and this gives rise to a characteristic dark shape on radiograph, the classic Mercedes-Benz sign or seagull sign. Here's a CAT scan of the abdomen of a patient with gallstone with the classic Mercedes-Benz or seagull sign. Bile microscopy. Bile microscopy aims to detect microcrystals of cholesterol or amorphous bilirubinate as indirect evidence for the presence of microlithiasis in bile. Bile microscopy has overall sensitivity of 65 to 90% for identifying patients with gallstones. Gallbladder microscopy. Here's a microscopic image of cholesterol crystals. Note that they are rhomboid in appearance with a notch at one corner. Here's another microscopic picture which shows amorphous brown bilirubinate crystals. Cholecystectomy or HIDA scan. Cholecystectomy makes use of the 99 technetium hepatoimmunodiacetic acid or HIDA scan. It is not used in the diagnosis of gallstones but is useful in excluding acute cholecystitis in patients who present with acute biliary colic. Treatment. Acute pain management for the biliary colic. During an acute attack of biliary colic, management is focused on pain control. It can usually be achieved with nonsteroidals. Other medications that can come into handy include opioids like morphine, hydromorphone, meperidine for patients who have contraindications to NSAIDs, or who do not achieve adequate pain relief with non-steroidal anti-inflammatory drugs. Most often, clinicians use ketorolac for patients who present to the emergency department with biliary colic. Patients are then prescribed oral NSAIDs for subsequent attacks that may occur while the patient is awaiting cholecystectomy. Here's the sequence of steps for the management of an adult with gallstones, which may be symptomatic or asymptomatic. First, an evaluation should be made to see if the patient is acutely symptomatic or not. If the patient is acutely symptomatic, be it the outpatient setting or the inpatient setting or the emergency department, an urgent evaluation and management is mandated. If the patient is not acutely symptomatic, then an evaluation of history of gallstone complications or gallbladder cancer risk needs to be evaluated. If the patient has history of gallstone complications or is at increased risk for gallbladder carcinoma, a cholecystectomy is generally recommended. If the patient is fit to undergo a surgery and is willing to undergo surgery. If the patient is unfit for surgery or is not willing to undergo surgery, non-surgical management for gallstones needs to be recommended, or an expectant management is to be followed. If the patient does not have a history of gallstone complications or is not at increased risk for cancer, a deeper evaluation of the character of the prior symptoms is needed. If the patient complains of a typical biliary colic, cholecystectomy is generally recommended if the patient is fit for undergoing surgery and is willing to undergo surgery. If not, non-surgical options needs to be evaluated or expectant management is carried out. If the character of the prior symptoms has been asymptomatic in nature, management is expectant in nature. If the character of the prior symptoms is atypical for gallstones, the patient needs to be evaluated with liver function tests. An unexplained cholestatic LFT pattern mandates evaluation for LFT abnormalities, and if no such LFT patterns are noted, then an evaluation for alternative causes for the symptoms needs to be made. Subsequent management. Elective cholecystectomy. For patients with typical biliary colic and gallstones on imaging who are surgical candidates, elective cholecystectomy is recommended in order to prevent further attacks of biliary colic and complications of gallstone disease. Cholecystectomy is typically performed laparoscopically, though it may also be performed through an open right upper quadrant incision. Major complications of cholecystectomies include bleeding, abscess formation, bile leak, biliary injury, and bowel injury. Cholecystectomy has also been associated with an increased risk for right-sided colon cancer, esophageal cancer, and small intestinal cancer. Gallstone complications. Acute cholecystitis is the most common complication of gallstones. Acute cholecystitis refers to a syndrome of right upper quadrant pain, fever, and leukocytosis associated with gallbladder inflammation that is usually related to gallstone disease. Chronic cholecystitis is the term used to describe chronic inflammatory cell infiltration of the gallbladder, which is seen on histopathology. Its presence does not correlate with symptoms, since patients with extensive chronic inflammatory cell inflammation may have only minimal symptoms, and there is no evidence that chronic cholecystitis increases the risk for future morbidity. Cholelithiasis with or without acute cholangitis. Cholelithiasis refers to the presence of gallstones within the common bile duct. Acute cholangitis is a clinical syndrome characterized by fever, jaundice, and abdominal pain as a consequence of infection in the setting of a biliary obstruction. Gallstone pancreatitis. The passage of the gallstones through the biliary tract can trigger acute pancreatitis either by obstruction to the flow from the pancreatic duct or by obstructing the ampulla of bladder, causing bile to reflux back into the pancreatic duct. Patients present with acute pancreatitis and can have elevations in liver chemistries, including elevations in serum bilirubin levels, alkaline phosphatase, and transaminases. Other rare complications of gallstones include gallbladder cancer, gallstone ileus, and Morizzi syndrome. Morizzi syndrome is impaction of a gallstone in the cystic duct, causing compression of the common bile or hepatic duct. We hope that you liked our video, and we look forward to seeing you in our next video. Thank you for watching.